Good evening, good afternoon, good morning, depending where you're joining us. Welcome to this webinar being hosted by the Michigan Urological Surgery Improvement Collaborative. My name is Khurshid Ghani. I'm a professor of urology at University of Michigan and director of the collaborative, as well as the principal investigator of a large clinical trial that we are working on here in the state of Michigan and throughout the United States, called the Stent Omission after ureteroscopy and laser lithotripsy trial. Today's webinar is going to be a focus on stent omission, and we're going to learn more about the trial. And as a practicing clinician, we want to teach you around some strategies and tips and tricks so you can implement stent omission in your own clinical practice. So welcome. Thank you for joining us. Let's begin. Disclosures are noted here. This study SOUL is funded by Patient-Centered Outcomes Research Institute, and music is funded by Blue Cross Blue Shield of Michigan, and my personal consulting relationships are noted on the slide. So we're going to talk about what the SOUL clinical trial is. Some of our faculty who are speaking today will speak about how providers may sometimes be concerned about stent omission and methods to address that. One of our faculty will be telling us how he implements stent omission in his clinical practice. We'll hear from an expert on maneuvers doing stentless ureteroscopy using the new, smaller, slimline ureteroscopes. And then we're going to hear from some of our surgeon scientists and other scientists in the field working in our clinical trial around views on stent use and other aspects about clinical trial engagement and methodology. I'm really grateful and excited to have an amazing faculty lineup of speakers, including John DiBianco from the University of Florida, Dr. C, my colleague here at University of Michigan, Dr. Madhu Gupta, MD urologist at Mount Sinai, Professor Ann Sales at University of Missouri, Dr. Stensland, who is a clinical trial expert here at University of Michigan, and my partner and the director of the Music Rocks program, Dr. Casey Dauw, also a co-investigator on this clinical study. We're also grateful to have the input of two patient partners who will be joining us along, so we welcome them and we're looking forward to their insights. So why does this study exist? If you think about a routine operation, such as a 1 centimeter lower pulse stone, that you have a ureteroscopy, what we found in Michigan and throughout the US is that many patients complain of pain. And most of that pain is leading to unplanned encounters, emergency room visits, clinic visits. And what we found in music is it's the presence of a stent that can increase the risk of this happening. So what do the guidelines say for stent omission? Both the American Urological Association and the EAU guidelines state that if you do an uncomplicated ureteroscopy, a stent is not needed. But what is the definition of an uncomplicated ureteroscopy? Well, the AUA is very prescriptive on that. You can see the guideline statements here: stone size less than 1.5 centimeter, no suspected ureteric injury, all the other factors noted on this slide. And that, despite there being some guidance and some criteria, the reality is that many urologists, and especially in this country, in the US, around 80% of patients are routinely stented after ureteroscopy. So why? Why do urologists continue to stent, despite guidelines saying it's okay not to? I think one of the major reasons that we see is around the evidence. This is an important paper published in 2019, a Cochrane review from investigators at University of Minnesota that looked at the evidence on stent versus no stent after ureteroscopy. There have been around 16 randomized controlled trials done in this field. And they concluded that stenting may slightly reduce the number of unplanned return visits. This was different to the findings that we found in music, but what they did caveat is that the evidence is uncertain. And they concluded that higher quality and sufficiently large trials are needed to better inform decision-making. So it is against this background that the music team, where our whole we're a community where our purpose is to improve patients' lives, is we worked with patients and put in a funding proposal to the Patient-Centered Outcomes Research Institute. And we put together the Stent Omission after ureteroscopy lithotripsy trial with the hypothesis that the Stent Omission is associated with improvements in patient-reported outcomes and 30-day healthcare utilization. We are looking at stones less than 1 centimeter in non-pre-stented patients without using an access sheath. And this is the type of patient that we consider would undergo an uncomplicated procedure. This is a very unique trial. It's a combined randomized and observational clinical trial. Patients are asked to be randomized, but those who decline randomization, and we found from our patient partners that many patients would decline randomization, are still offered the option to be in the observational arm, which is very unique and has never been done before in this in the study of stent omission. Also very interesting and unique is that patients and surgeons are assessed by our scientists on the team for their preferences and their attitudes around stenting. So we're going to understand this much more as a result of this clinical trial. Our co-primary endpoints are PROMIS pain interference scores at 7 to 10 days after surgery, and also unplanned healthcare utilization within 30 days, looking at a composite tiered hierarchical metric of increasing healthcare utilization based on the severity. We are fortunate to have 17 centers across the US being involved in the study, and you can see all the sites noted here. And we began the study on June the 1st, 2023. We have enrolled 715 patients so far. That's been amazing. Our target is 931. And we are really close, and we hope to wrap up the trial the second half of next year. You can see that 37% of patients agreed for randomization. So this is the largest clinical trial on stent omission to date in the world, and also one of the largest prospective clinical trials in ureteroscopy. This study would not have been possible without the support, the enthusiasm of all these talented and amazing surgeons who are all part of our clinical trial. More than 40 surgeons are involved. This is phenomenal. And so I'm just so delighted to have this session today. I hope you enjoy it. I'm now going to pass it on to Dr. John Michael DiBianco at the University of Florida. John was our endourology fellow here at University of Michigan some years back. Was an excellent fellow and actually helped us at that time when he was working in music, help us brainstorm and design aspects of this clinical trial. So I'm just so delighted that I can hand over the first talk to John, who will tell us about his feedback as a clinician enrolling in this trial at the University of Florida. Thank you, John.
Thank you very much, Dr. Ghani. And thanks for the opportunity to talk about tips and tricks for stent omission. As Dr. Ghani may have mentioned, I'm John Michael DiBianco, endourologist at the University of Michigan and co-director of the BPH program. So my story, I was born and raised in Washington, D.C. I did research at the NCI, went to Ross University for medical school and George Washington University for residency. And I had the pleasure of training under Dr. Ghani and Dr. Dauw here at the University of Michigan for my endourology fellowship. And at George Washington, I had the opportunity to learn from Dr. Patrick Mufarge. And I was taught there that stents are very good. So we stented everybody all the time. When I got here to Michigan, I learned that stents are very bad. And we practice stent omission quite often. So when I was trying to figure out what am I supposed to do in practice, this was me. I was sort of a bit confused about how I should proceed moving forward. So what did I do? I went to the guidelines. And so the guidelines say that we may omit stents in uncomplicated ureteroscopy. The EAU is a little bit more assertive, saying that you do not need to insert ureteral stents when it's an uncomplicated ureteroscopy. And the UK says that stent omission is indicated in for patients and procedures that are treating ureteral stones less than 2 centimeters. So my stenting algorithm and stenting options became short-term stent, long-term stent, and then stent omission made an appearance. And so what I learned in practice was the best way to start is to just start. So just doing it. If you don't start doing it, you're never going to feel comfortable enough to do it. And luckily, at the University of Michigan, they came up with some criteria for how to guide which patients to omit stents on. And so in particular, pre-stented patients with less than 1.5 centimeter stones or non-pre-stented patients with 1 centimeter stones in the uncomplicated ureteroscopy were the patients that I focused on. So then I joined a practice at the University of Florida. Now, when I got here, I was very excited and wanted to kind of gauge what the culture was about stent omission, whether that was something that was done. And I soon found out it is not what is done at the University of Florida. So the culture was for stenting, which is pretty common. So then I had to figure out, do I do what I feel is right for patients, or do I try to conform? Because I don't want to be the guy who caused my colleagues to have to come in the middle of the night to place a stent because the new guy did not put a stent in a patient they, in their eyes, would say they should have. So how did I start? So I identified the relatively easy ones. So the chip shots, the pre-stented patients with large ureters with smaller stones, avoided complicated patients, patients with recurrent UTIs or UTI history, blood thinners. And I also gave patients my number, not always my cell phone number, potentially a Google number, which I could always change and cancel. But I wanted to be the one to know about any issues first before my colleagues or anybody else was aware of them. And so here's my technique. We've been doing this for quite some time, for a little over 3 years now, and knock on wood, things have been going quite well. So preoperatively, I get a urine culture on everybody. I write everybody, if they're not already on an alpha blocker, for Flomax or for 30 days, and I instruct them to start it 10 days prior to the procedure. I give them the music information about stents and about ureteroscopy, and I discuss with them. Intraoperatively, if they don't have a stent in already, I will go directly in with the ureteroscope. I usually use a safety wire, usually a zip or glide wire. I'll come back out and I'll go back in and atraumatically enter the ureter and hopefully perform an uncomplicated dusting procedure, grab a piece of the stone on the way out. And if everything has gone well in an uncomplicated fashion, I will omit a ureteral stent. Post-operatively, they all get the music cocktail, the music educational material, and they continue to take that 20 days that they have left of the alpha blocker. And so these are my endourologist colleagues, and I'm happy to say that 90%, if not all of them, have performed stent omission since me getting here, and some of them perform it quite often. So knock on wood, we're doing quite well with that technique. And so in conclusion, what I'd say is that stent omission can be safe. It is possible to learn. I myself was not at all comfortable doing it prior to my fellowship. I would definitely say start with the easier cases, the less complicated cases. Education of your patients is incredibly important. They need to be a very active participant in this process. The use of alpha blockers, I think, is very helpful. One, for stent discomfort when they have to be placed, also for preparing the ureter for an uncomplicated ureteroscopy, and potentially for the assistance in the passage of dust. I would definitely say be available. If you're at a culture or practice that this is not typically done, you want to be very available so that you don't seem like you're doing anything negligent or new or dangerous to your colleagues. And track your outcomes. I have an epic list that I keep these patients in, and I want to be aware if there's any issues and if I'm doing maybe my criteria for selection is incorrect. But with that, I'm going to hand it off to Dr. Wilson Swee, and thank you very much for the opportunity.
Thank you so much, Dr. DiBianco. I'm here to give a little bit of an opposite perspective on stent omission. My name is Wilson Swee. I'm an assistant professor here at Michigan. And so just a little bit about myself. I grew up in the Northeast and then did med school down in the Northeast as well before going to Nashville, where we had our daughter, and then the West Coast, where we had our son, and then finally ended up here in the Midwest for an attending job. And I have that sort of long-winded introduction because really this was the paradigm to stone surgery. It was, after all, why not? Why shouldn't I put in a stent afterwards? And here are some of the people I trained with. And one of my co-residents, Dr. Hall, who's here in Michigan with me, can back me up on this, which is that we just sort of stented everyone. And stent omission never really came up until I joined the staff here. And here are some of my many esteemed colleagues. And within the first few weeks of me starting here, they said, why do you stent everyone? What are you doing? One of the pieces of advice I got before starting as a faculty was to trust your training. So that put me in a very sort of interesting position where I started, we started talking about stent omission and it was almost part of the culture here. But where I trained, we really didn't talk about it too much. And so I had sort of a stent dependence issue. And so here's a 5-step program that has really helped me become better about stent omission. Step 1 was admitting I have a problem. And so how did we find that out? Well, in counseling our patients here, I tell everyone, hey, so at the end of your ureteroscopy, we'll put in a stent. And in fact, there's so much stent omission going on. This is an actual quote from one of my patients who said, hey, yeah, but, one of your colleagues, Dr. Mansour, across the seat, says he does not put in a stent at the end, and we didn't do it last time. Why can't you do the same thing? So coming in from outside of Michigan, you sort of are a kid in a candy shop looking in on how things are going. When you're actually here and you're involved in music, you really get to see and feel this sort of indirect peer pressure of, hey, everyone else is doing this, or a lot of other people are doing this thing. Why aren't you doing it as well? And so that has been another way for me to recognize that, hey, maybe this is a problem. Maybe this is something that I shouldn't be doing anymore. Step 2 is recognizing the harm. Well, you can look at the data, and this is sort of a well-trodden slide where that showed Dr. Hiller and Dr. Dauw, Dr. Ghani's, some of their seminal work on this, which was that patients who had stent placement after urology tended to come back to the ED at a higher rate. And then so I started really talking to patients about this. So, and this is another real quote where I'll say, so at the end, we put in a stent, and one of my female patients said, I would literally prefer to have anything else other than a stent, even have another kid or 2. Step 3, data therapy. So here's some of the unpublished work we had from AUA from this past year showing that, before and after the value-based repayment, the stent omission rates really did go down here in the state of Michigan. But the question was, did the ED visits change at all from that? And no, we still saw that not putting a stent led to lower ED visit rates, even though we were not stenting more people, which was reassuring for me to say that, hey, even though we're probably being more aggressive about stent omission, we're not really increasing the risk of patients coming back to the ED. Nonetheless, it's still challenging. You see in the stent naive patients, it's still a harder population to really stent omit for. But if we look at some of our other data, and this again was shown at AUA this last year, in terms of access sheaths placement, well, even in patients that are pre-stented, a fair bit of them don't go on to get a stent afterwards. And then in the non-pre-stented patients, there's a minority, and this is probably consistent with most people's practices, who don't get a stent afterwards. But again, we still find that people who don't get a stent tend to come back to the ED with a less risk than the people who do get a stent. And sort of the proof is in the pudding. I remember the first time I did this for someone, and it goes against all the training I ever had in urology. And I said, hey, like we talked about, I didn't put a stent in. And the patient said, hey, can you just give me apple juice? I feel sort of good right now. This is the best surgery I've had in a while for kidney stones. And those positive instances have really helped for me reinforce the benefits of stent omission, even as soon as seeing someone in the PACU. I think that finding support is important, and that's part of, this is a scene from The Matrix, freeing your mind. And in this case, it's freeing your mind from needing to put a stent in everyone. Part of it was finding very supportive colleagues. Part of it was having the privilege of putting people into a trial and to lean on that and say, hey, I'm putting you in a trial. That's why we're doing this. And it's been working for other people. And certainly having, my colleagues every week when I come back with no patients enrolled in the trial, giving me a grumpy face helped with some of the incentive too. I think other things that have really helped is really trying to optimize people beforehand. And so this is a nice review paper on the benefits of alpha blockers before ureteroscopy. And it really showed that there's decreased, negative ureteroscopies because you couldn't get the scope up and the need for dilation. No touch, this is something I was doing in training, but I think this has certainly helped me get away, or at least mentally get away with feeling better about not putting in stents in patients, especially when you can navigate the ureter pretty easily just with one pass with a ureteroscope. And then technology, as scopes continue to get smaller, are we going to feel more comfortable with not putting up a stent afterwards because the ureter is easier to navigate, because you feel like you're doing less trauma, I think is also hugely beneficial. And step 5 is really just embracing the stent-free lifestyle. I will admit not everyone is stent-free. I don't stent omit everyone, but things that have, again, really helped is enrolling people in the clinical trial. Even when I do minor dilation, I feel comfortable putting no stent in. And then in the pre-stented population, this is easier. But even now when we're putting a sheath up, oftentimes I don't put in a stent afterwards. And we have a randomized trial out now on that we're accruing for. And similarly for patients that come in with infection or were infected beforehand, I think the Delphi panel that music has run for that has opened my eyes in terms of antibiotic practices. And, it's sort of, as a new faculty, it's sort of you're a dog on your own leash and you're leading yourself. And so for me, it's one case at a time, really trying to push the envelope on stent omission. And here's a nice summary of the 5-step program, and I hope it helps people. That's all I have. Thank you. And now it's time to turn it over to Dr. Dauw.
Thanks, Wilson, and John Michael and Khurshid for kicking us off. It was a great start to the webinar tonight. So I have the pleasure to be joined by a patient advocate, Janice, who will kind of gear much of the discussion towards, as well as Dr. Swee, who just gave that great presentation. And so, Janice, thank you so much for being here with us today. I think what's really unique about your story, and I'd like to hear a bit more, is that you are actually a sole trial patient. So you're intimately involved with how this all works. Can you tell me a little bit about your experience in the past with kidney stones prior to your enrollment in SOUL?
Sure. Well, first of all, thanks for having me. It's a pleasure. I had previous experience, 3 stents placed prior to my last experience, so 4 stents in total before I was part of the trial. Not good experiences, did not like having the stent, very uncomfortable, painful, frequent urination, painful urination, stressful, knowing that it was there and it was going to have to come out. It was uncomfortable, just all of them were like that. And when I went into this latest experience and they asked me if I wanted to be part of the trial, of course I didn't want to have another stent.
Yeah. So I guess that's the most interesting question to me potentially is, based on your prior experiences, what were the factors that led you to be willing to be randomized, right? A coin flip between stent placement and stent omission.
I guess when I thought about it, I thought if I was going to participate, I was going to do what was best for the study. So if I was going to agree to do it, I might as well do it right. So you could get the most information that you could out of my experience. And
so I know your case, but tell us then. So you show up for surgery, you're crossing your fingers that you're going to be in the 50% no, but what happened?
Well, I got it. I guess it was my lucky day. So I got the stent and you just deal with it. I wasn't real happy about it, but it was the luck of the draw.
Did you feel like one of the things that John Michael said, the University of Florida urologist, in the first talk that we had was how important patient education is related to a stent. So if you think back now, you've had a stent 4 times, right? Do you feel like there's been any evolution in your education around stenting, and hopefully that in enrolling in the SOUL trial, though you had your own personal experience, that we might have done a better job of educating you as to what we could do to mitigate stent discomfort if you were in that group?
I believe so. And part of that might have been just too having the experience and learning a little bit each time. But I do feel as though my concerns were addressed and I was listened to, that I was at least given the option of whether or not I wanted to participate in the trial. Mm-hmm. I felt when I first started experiencing kidney stones, I really was just kind of at the mercy of whatever they told me I needed to do. And you trust your doctor and you do what your doctor says. Yeah.
So another question I have that came up from John Michael's talk and was discussed a little bit in Wilson's talk is this notion of, we're fighting inertia here as urologists. A lot of our practices are ingrained because of years and years of training, and those people that trained us had years and years and decades of training. What are your thoughts and feedback around the idea that the urologist might give you his phone number, whether it be a Google number as suggested or their personal cell phone number? Have you experienced that before?
I have not, and I like that idea. Just because it's new to most people that experience it don't know all the questions to ask right from the get-go, and they're going to run across some situations where they'd like to ask some questions. And I think for me, that would have been helpful.
Yeah. So
those 4 times.
A couple of the urologists that retired from a group that the University of Michigan acquired were really consistent in doing that for all their patients. And I remember, much like John and Wilson were shocked that we were stent omitting, I was shocked that you would give up your freedom essentially to give a patient your cell phone number. And their comment to me was, the patient's only going to call you if they absolutely need to. And that's it. And so I have tended to do that a little bit more in my practice. And I think that that's a really good point that was brought up by John Michael. So in the couple minutes that we have left, and Wilson, chime in for sure if you have any questions that we haven't addressed. What was your experience like this 4th time? You wake up, you're randomized to stent. How did things go?
Well, I had a lot of the same symptoms I had the first 3 times, where it just was uncomfortable. I was disappointed, of course, because I was hoping that I was going to go without the stent. And I think the stress just started to build of knowing it was there and it was going to have to come out. And I just didn't like that idea. That was more stressful to me than whether or not I was going to get it in the first place, I guess. I just didn't like the idea of knowing it was there. And it was uncomfortable.
Yeah, well, I mean, what I can say is these sorts of interactions with patients like yourself, for sure, kind of color our feelings about enrolling and participating in this trial. I think it's pretty powerful that you were willing to, submit to the coin flip, so to speak, because of the, benevolent reasons, which is to participate in a trial that may answer some of these questions. And so I, for one, appreciate it as a co-investigator. And I think, we'll hear from Dr. Kevin Tim later in this webinar, also a patient, that similar feelings are shared by other folks that are involved in this trial. And I think, the hundreds of people that have been willing to participate to this point. So, Janice, I think that you're a rock star for the trial, and hopefully that's the last kidney stone event that you have, or the trial will be closed and Dr. Ghani will just not put a stent in. So with that, thank you so much for your participation and your insights here. And I'm going to